Welcome to the September 2023 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. Today, we are featuring the content of the September 2023 issue. My name is Alice Cheng from the University of Toronto.
And I'm Mike Rickles from the University of Pennsylvania. As per usual, Alice and I will be interviewing authors of feature articles as selected by the editors of Diabetes Care, followed by our rapid exchange segment where we give brief summaries of articles we each found of particular interest this month.
And this month, we'll also be featuring a special episode covering this year's Diabetes Care Symposium from the American Diabetes Association meeting on the impact of social determinants of health for diabetes development and care. So look out for this important panel discussion with the symposium speakers and article authors coming out shortly.
Well, let's get started with our feature article interviews for September 2023. In the September 2023 issue of Diabetes Care, one of the feature articles is a review entitled Diabetic Nephropathy, Update on Pillars of Therapy Slowing Progression. Diabetic kidney disease is one of the most prevalent complications of diabetes, and as pointed out in this article, affects 700 million people worldwide, disproportionately those who are socioeconomically disadvantaged, and increases mortality due to both end-stage kidney disease and cardiovascular disease events. Given diabetic kidney disease affects about 40% of individuals with diabetes, I know that I am addressing the management of this problem in every clinic session. And with several recent new drug approvals, I found this article both extremely practical and timely. I'm very glad that we have with us both of the article's authors, Dr. Sandra Naaman and Dr. George Bakris. Dr. Naaman just completed her endocrinology fellowship at the University of Chicago, where she had previously practiced in internal medicine. And Dr. Bakris is professor of medicine in the section of endocrinology, diabetes, and metabolism, and director of the Comprehensive Hypertension Center at the University of Chicago. Welcome, Sandra and George. I'm delighted you could both join us.
Happy to be here.
Thank you for having us.
Well, congratulations, Sandra and George, on your feature article. You put forth a concept in diabetic kidney disease management you term pillars of therapy. The main pillar remains blockade of the renin-angiotensin system with either an angiotensin converting enzyme, also known as ACE inhibitor, or an angiotensin receptor blocker, ARB. Both can reduce albuminuria and slow the rate of kidney function decline. But as your article points out, they still leave a significant residual risk, and so there's substantial room left for improvement. Curiously, prior studies that combined ACE inhibition with an ARB or tried direct inhibition of renin had not added net benefit. So I'm wondering if you can explain why this residual risk remains and why these other approaches to blockade of the renin-angiotensin system haven't made it to clinical practice.
There has been, with the initial discovery of ACE inhibitors slowing kidney disease progression in diabetes in 1993, and then in 2001, the two landmark studies of RENAL and IDNT, it was clear that this system was very important. So we had nothing else at the time mechanistically. So everybody jumped on this and figured, well, if we block the system better, things will be better. Well, it turns out that the only thing that was better is that you had more hyperkalemia. And it really was not better. And in fact, there were other side effects that went along with that. So that was not the answer. And the risk is coming not just from the blood sugar. That was the naive thought 30, 40 years ago. It's coming from the underlying inflammation and subsequent fibrosis that develops because of not just the blood sugar, but the blood pressure and other factors. And the renin-angiotensin system does a good job on reducing the inflammation, but it clearly doesn't stop it. So that's the residual risk, is what's left over that the RAS blockers can't do. I don't know if you want to add anything to that, Sandra.
I think that, the pillared approach really speaks to the complexity of the underlying pathophysiology. Essentially, in our article, we talk about three broad processes that interplay with each other: the hemodynamic, metabolic, and inflammatory. But as Dr. Bakris articulated, inflammation is really central to many of these disease processes, particularly chronic kidney disease. And so it underscores the need for multi-targeted therapies with distinct pharmacodynamic actions to halt disease progression.
That's great. And so, as you mentioned, the first positive results for renin-angiotensin system blockade showing slowed progression of diabetic kidney disease, it came with the Captopril trial in 1993. And then the field waited a long time for a new class of drugs that could produce similar or additive effects to what had been established with RAS blockade. So your article points out that this next class really came in 2014. So after more than 20 years, with the introduction of sodium glucose cotransporter 2 or SGLT2 inhibitors. While positive effects on reduction in albuminuria and the rate of kidney function decline were initially identified as secondary outcomes from trials focusing their primary outcomes on cardiovascular disease events, the benefits of multiple agents from this class on primary kidney disease outcomes has now been confirmed in several trials. And importantly, these benefits have now been shown on top of established renin-angiotensin system blockade. So, how is this second pillar of diabetic kidney disease therapy working to provide added benefit? And when should we be considering SGLT2 inhibitors for our patients?
There's a couple of language things that we've talked about that I want to make sure the audience is clear on. Where did this concept of pillars of therapy come from? And the short answer is I stole it from the heart failure cardiologist, because the heart failure cardiologists have been using pillars of therapy for treatment of heart failure. And they've now established 4 different drugs that, when used together, actually give you dramatic benefits in outcome. And so I thought, okay, we now have more than just the ACE inhibitors in diabetic kidney disease. So why don't we just apply that? And I figured it would be familiar nomenclature. So that's where that came from. That's number one. Number two, you've mentioned albuminuria a few times. Let me just say for the audience, in case they're not aware, in the ADA guidelines dating back now to 2021, I put in there, with, of course, the committee's approval, a specific statement as a guideline that you need to reduce albuminuria by greater than 30% to get better renal outcomes. So it's not just reducing it, it's got to be greater than 30%. And that comes from very large analyses that have been done of multiple trials. So that should be a goal. Yes, it's a surrogate, but it's a surrogate that correlates with better outcome. So, important points. Now, having said all of that, SGLT2s, when they were originally described, they were going to be glucose lowering agents. But surprise, surprise, when the GFR goes below 60 and definitely below 50, they do nothing to glucose. And yet the benefits are wild and great in terms of both heart and kidney, reducing heart failure progression and reducing slowing of kidney disease. So when should you use them? Well, if you look at the data, the totality of the data would say anybody with albuminuria and or a GFR of greater than 20 absolutely should be started on them, because they will, along with ACEs and ARBs, slow progression of kidney disease.
Now, George, in 2020, you led a study reported in the New England Journal of Medicine that showed the non-steroidal mineralocorticoid receptor antagonist finerenone can also reduce the rate of diabetic kidney disease progression when added to renin-angiotensin system blockade in individuals with type 2 diabetes. And your article points out that the steroidal mineralocorticoid receptor antagonists, spironolactone and eplerenone, while effective for refractory hypertension and in heart failure, had been limited in the study of diabetic kidney disease progression by the high incidence of hyperkalemia, as you noted previously on efforts to further block the renin-angiotensin system with additive agents. And this especially affected those with lower estimated glomerular filtration rates. So, how is this non-steroidal mineralocorticoid receptor antagonist working differently? And when should this, as you describe, third pillar of diabetic kidney disease therapy be considered for our patients?
Great question. Let me give you a little background. I was asked to kind of put together a team and put these studies together, because it wasn't just the Fidelio trial that you brought up, but it was also the Figaro trial, which was a cardiovascular outcome trial that was being run in parallel. So interestingly, if you look at the data, total numbers, if you want to be kind of evidence-based, if you look at the total number of people we have with kidney disease in SGLT2 land, it's about 11,500 people. If you look at the total data with finerenone, it's 13,000 plus. So we actually have more data with finerenone than we do the SGLT2s. So that's number one. But the goal is, what's new about these agents? There was a pharmacologist that had been working on developing a new kind of related class of agents in this area that would block aldosterone for over 10 years. And finerenone was the one candidate that came out of this. So this was not a by the way finding. What are the differences? Nonsteroidal MRAs do not go through the blood-brain barrier. They do not have any sexual side effects. They bind with a receptor in a tighter way than do either spironolactone or eplerenone, and as a result, stimulate different genomic messages. So we don't know exactly the details of what that means, but one of the other things is finerenone has a very short half-life. Anybody that knows anything about spironolactone knows that with metabolites, it's going to be floating around for 2 to 3 weeks. Finerenone is a 2 to 3 hour half-life. And even eplerenone, which is a little bit different than Spiro and clearly different than finerenone, has a half-life that's double to triple what the finerenone half-life is. This class of agents, the finerenone is the first in the class, but there's actually 4 other drugs in the class. Those are being developed for blood pressure, not renal outcomes. But the other important thing is the FDA has named the non-steroidal MRAs as a different class of agents. It's not your mother's Spiro. So even the FDA has acknowledged there are different chemistries, there's different outcomes, there's different profiles. And one of the things that was really distinctive here, and we've done further studies other than the one that you've talked about, is much lower levels of hyperkalemia. Yes, you get hyperkalemia, but much lower levels. And one of the advantages of combining SGLT2s with finerenone is you actually get a protection against hyperkalemia that nobody really understands why. And because this is in people with GFRs of 30. So it's very interesting how we stumbled into this. And I just want to say, in thinking about this, the pillars of therapy, you make it, sequential. Well, we had the RAS blockers first, then we had the SGLT2s. And by the way, the trials with SGLT2 were ongoing when we designed the trial. So they came out before we did, but nevertheless, that's why we have some people on all 3 meds. But I think it's important to think, for the audience's standpoint, that if you have somebody that has a problem with SGLT2s for whatever reason, side effects or whatever, finerenone should be immediately thought of as equal to SGLT2s in terms of heart failure benefit and slowing progression of kidney disease. So it's a sequence of timing that it's like this, but it really should be thought of because everybody was on a RAS blocker with finerenone, and the results were very similar to what you got with SGLT2s. And there's more people on finerenone, so there's no reason to not interchange the two. But of course, using all 3 is better.
Terrific. So there's really, after the RAS blockade of the first pillar, the second and third pillars really are equally effective agents and could be chosen either one sequentially following another based on the patient in front of you, and or potentially as a combination. I wonder, given what you mentioned about the protection of hyperkalemia imparted by SGLT2 inhibitors, is there any move in industry to make combination products of an SGLT2 inhibitor with finerenone, for example?
Well, it turns out there's not only a movement towards that, there's a publication that was published in, I believe it was Diabetes, Obesity, and Metabolism. But the point is, it's not finerenone. It's a finerenone-like compound that was put together by AstraZeneca. And then there's actually, that is not the publication. The publication is with eplerenone. And, eplerenone's not a very good blood pressure lowering drug, by the way, not compared to Spiro. And when you look at it, its antihypertensive effects are pretty similar to finerenone, which a lot of people don't appreciate because we didn't make a big deal out of that. But it does have blood pressure lowering effects in people with higher pressures. So Yes, it's there. Yes, there was greater albuminuric effects, but there's no outcome data with any of this.
Your review also proposes a fourth pillar of diabetic kidney disease therapy, namely treatment with GLP-1 receptor agonists. These agents have also demonstrated delayed diabetic kidney disease progression as secondary outcomes in primary cardiovascular disease outcome trials. And your article points out that the primary outcome trials focus on kidney disease outcomes are currently in progress. So here, the mechanisms affecting the kidney by GLP-1 agonists seem less direct. And Sandra, you talked about earlier inflammation and fibrosis and other mechanisms beyond hemodynamics within the glomerulus that can affect progression of diabetic kidney disease. Can you explain how these agents are believed to impact progression?
Sure. I think our understanding of the underlying mechanisms of the GLPs is still in evolution, but the most obvious mechanism would be related to weight loss, and then the subsequent improvement in the metabolic parameters, namely hypertension and hyperlipidemia. And of course, decreases in blood pressure. But notably obesity, and specifically abdominal obesity, with normotension and normoglycemia, is an independent risk factor for albuminuria. And so that sort of addresses a subset of patients who may come across as or be screened or classified as metabolically healthy, when in fact the underlying inflammation is driving the underlying CKD. And so with the newer drugs, some of those newer GLPs, the weight loss is incredible, can reaches up to 20% sometimes. If the drugs are continued, the weight loss is often sustained. And so the flow is an ongoing trial, the results of which are expected to come out soon. Dr. Bakris knows probably exactly when, but this is the first trial that actually has hard outcome data for kidney variables as the primary variable, and we can glean from those results the effect of that drug class on CKD progression. But I think the underlying, the most obvious mechanism is weight loss, and then the underlying inflammation that's engendered by the obesity.
And so that's adipose tissue inflammation that then is operating through an adipose renal axis to promote local inflammation or activate fibrotic pathways in the kidney that leads to kidney disease progression in obesity?
Essentially, the adipose cells undergo hyperplasia, hypertrophy, and then there's an interplay. There's sort of like a cytokine storm that lives off in these crown-like structures, and that's an area that's been studied extensively, where basically the immune response shifts towards a pro-inflammatory milieu, and that is one of the processes that we talk about that drive underlying kidney disease and many other chronic conditions. Also, it's that push towards inflammation, or sort of that M0 state, if you will, that fosters more of the inflammatory cytokines.
Let me add to that for the audience because they may not be up on immunology and all the stuff that Sandra's talking about. But one of the things that they do know is aldosterone. And one of the things that a lot of people do not appreciate is that adipocytes, visceral for sure, and even some evidence for subcutaneous, release aldo. So the more adipocytes you have, the more aldo you're going to have. So that doesn't relate directly to the GLP-1s, but it relates to mechanisms of inflammation and those kinds of things. So, to your question, I was in a panel a few years ago, and one of the panel members was Dan Drucker, a very famous guy from Toronto, especially with GLP-1s. And I asked him, I said, "So Dan, they're asking me what the mechanism is or kidney protection. What is your answer to that?" He goes, "I don't know." So I think when the who's who doesn't know, we're still kind of searching for things and speculating on things. But weight loss is the missing link, and it's a critical link. Now, the other thing is the dose that we're using in the flow trial is not going to lead to a tremendous amount of weight loss. You're going to lose some weight, but you're not going to be dropping 10, 20 kilos. It's nothing like that. So there is a component to it. It is important, but we really just don't know. And by the way, for the audience, since Sandra brought it up, the flow trial is supposed to finish. We're supposed to know the answer in April of next year. However, there's a peek at the data in January. And if it's overwhelmingly positive, it may stop even then. But that remains to be seen.
Terrific. So that's fascinating about the weight loss for sure and how adipose tissue effects can come back to aldosterone. And with that, I'm going to bring it back to these agents that can have as well primary hemodynamic effects within the kidney. So the first three pillars, renin-angiotensin system blockade, SGLT2 inhibition, and mineralocorticoid receptor blockade. With all of these, one can see treatment-related initial decline in estimated glomerular filtration. And your article points out how such an initial reduction in glomerular filtration may in fact be associated with long-term protection from progressive loss of kidney function. However, I still get nervous when I see a treatment-related increase in serum creatinine. And I think a lot of us worry about causing potential harm from acute kidney injury in our patients with diabetic kidney disease. So how much of an increase in serum creatinine is okay with each of these drug classes?
So I'm going to answer that because that's something that Professor Matt Weir and I started back in 2000. Everybody tries to prove us wrong, and the data keep coming out the same, and so no one's proved us wrong. So what's the magic number? The magic number is you should allow for up to a 30% sustained increase in serum creatinine. So if it's less than that, you do nothing. If it's 30%, you check it soon, like within the next month or less. And if it continues to go up, then you got some injury that's going on and you need to stop it. But by far the most common reason is volume depletion. People are not drinking enough fluids. And one of the ancillary ways you can figure this out is look at the blood pressure drop from ACE inhibitors or ARBs. If it's profound, then you've either got renal artery stenosis or you're volume depleted. I mean, those are the only two things that are going to really give you that drama with those drugs. So I think you have to think about it. No one's been teaching residents this stuff. That's the problem. So everybody's hung up about this. And with all due respect, my colleagues who I've talked to about this have put this in the AKI guidelines. And that 0.3 for the audience is garbage because that 0.3 has been derived. Even the first author has recanted that data. It was hospitalized heart failure patients. And what they realized is if the creatinine goes up 0.3, there was higher mortality in those patients. I can tell you all my heart failure cardiology buddies who are academics think that's garbage and they don't pay attention to it. All right. And like I say, that was published in 2000. So I think one has to be very careful. 50% increase, no one's arguing that's AKI. But AKI, the most common predisposing cause, is volume depletion. So we're back to where we started. So, final thing, and Matt Weir and I published an editorial on this within the last 6 months. You do not want to start all these agents at once, because if you do, you are going to get more than the 30% increase in serum creatinine, and that's a problem. So, RAS blockade at maximal dose. That's important because most people don't use maximal dose. The protection is at maximal dose. Then get stable, wait about 2 weeks, 4 weeks, then add whatever you're going to add, finerenone or an SGLT2, not the two together. Then wait another 2 to 4 weeks and then add whatever you didn't add. It's not like, well, it's there just in case. You need to have all three. And so that's the way it is. And then the GLP-1 is going to have to be added down the road. If it turns out to be positive, that would be the fourth pillar.
Terrific. Now, one other safety related question is given the risk of euglycemic diabetic ketoacidosis with SGLT2 inhibitor use, particularly in type 1 diabetes, and to my knowledge, the studies on diabetic kidney disease outcomes for finerenone and GLP-1 receptor agonists have yet to be completed for individuals with type 1 diabetes. And so, how do you recommend we apply these pillars of therapies to our patients with type 1 diabetes?
Sandra, go ahead, and then I'll fill in.
Sure. So diabetic kidney disease typically develops after diabetes duration of about 10 years in type 1. The most common presentation is somewhere between 5 to 15 years. And so a pillared approach would still be applicable with some caveats. We would still apply RAS blockade because some of these earlier studies did include type 1 patients. To your point about the SGL2s, sort of the metabolic and the renal benefits of SGLT2s do extend to patients with type 1 when added to insulin. That's been shown. The issue with the euglycemic DKA, I think to some extent relates to the detection rate more so than the frequency. Yes, there is a frequency component, but I think it's the detection that's the problem, because the blood sugar levels don't reach a point where they could be readily picked up by the patient and the clinician in a timely manner to offset complications. And that's because we know the way SGLT2s work, they create a negative caloric balance via drug-induced glucosuria, which promotes ketone generation without hyperglycemia. And so the agreement is proceed using these drugs, but with caution in a sense. But if they're used in addition to finerenone, maybe Dr. Bakris can comment a little bit more about that. But just talking about the SGLT2s, I think other than a GFR less than 20 to 25, there'd be no issues to preclude finerenone use in this patient population. But we're still hung up on the euglycemic DKA related to SGLT2s before we can move on to the next pillar.
Yeah, and that gets back to what I was saying, that SGLT2s and finerenone should be synonymous with each other. So it's not like you can't use finerenone if you don't have an SGLT2. That's ridiculous. The other point that what Sandra makes, I have as a nephrologist, I have 3 patients who are type 1s who are on SGLT2s. I'm very hesitant to do that because I have seen ketosis from that. Why are these 3 patients doing so well? Because they all have, by the psychiatric definition, obsessive compulsive disorder. So these are people that listen to everything I say. They've gotten keto sticks, they're checking them. They have reduced their insulin dose, but not so much, because as they found out when they pushed it, they developed ketosis. And luckily, they called me. We got them. They did not go to the emergency room. We treated them at home. They did fine. But you cannot willy-nilly give SGLT2s to type 1s. There's no way I would ever endorse that. And if you're going to use them in type 1s, they better be highly obsessive compulsive and you have a good rapport with them. Otherwise, forget it. And they need instruction.
Is there any evidence about dose-related effects? That is to say, would you be more likely to get away with just sticking to the low starting dose of an SGLT2 inhibitor if you were considering it in type 1, or are you not going to get the renal benefits you're looking for?
Every single trial that has been published with the type 2s, 100% have been at the starting dose. They're really not using. I mean, DAPA is an exception. DAPA is an exception because they did use 10 milligrams. But for the other 2, it's the starting dose. None of them pushed it to the upper dose.
Great. So that is super, super helpful. And I think I'm going to use this as guidance as I am approaching my patients and discussing additional agents for preventing progressive diabetic kidney disease. Do you have any final takeaway messages for our listeners?
I think recognizing the complexity of the underlying pathophysiology of chronic kidney disease enables us to use this approach with more reassurance as our understanding of the underlying pathophysiology deepens, and the results of the trials, the totality of which are very convincing that this is the way to go. I think we're in a very, very good place right now regarding halting the progression of chronic kidney disease. Hopefully the GLP trials will provide positive results to really complete the picture.
I would say as we've entered now into the early part of the 21st century, we have a huge impact on what before was a guaranteed death sentence or a time to dialysis sentence. And so now we can generally change that dramatically, but you got to do it correctly. So, concepts. Number 1, the finerenone and SGLT2s in people with low GFRs, people with GFRs definitely less than 50, they are synonymous. You do not need to give an SGLT2 first and then wait, and then you can give either one first because the data is equivalent in that group. If you're using it for glycemic control in people with GFRs that are higher, that's fine. You can start with the SGLT2 and go from there. Do not start them all at once. Allow yourself a few weeks for the kidney to recalibrate, and then you can start. And you will get a drop in GFR with each time you add something. So it won't be huge, but you'll get it. So just keep that in mind. And then lastly, I want to leave you. There's a lot of confusion, I think, on the part of definitely cardiologists and some endocrinologists that SGLT2s are antihypertensive. They are not antihypertensive, period, end of discussion. Yes, they drop blood pressure about 3 millimeters. And yes, if you have a hemoglobin A1C of 9, they're very antihypertensive because you get an osmotic diuresis if you have normal kidney function. That does not make them antihypertensives. So let's be clear on that. So open your minds and think of pillared approaches now, just like the heart failure cardiologists do for treating diabetic kidney disease to maximally achieve cardiorenal benefits.
Thank you, Doctors Naaman and Bakris. I really appreciate your both joining us today and teaching us about your four-pillared approach towards slowing the progression of diabetic kidney disease. I encourage all our listeners to access the full article in the September issue of Diabetes Care, and thank you for tuning in.
One of the feature articles from the September 2023 issue of Diabetes Care is titled Artificial Sweeteners and Risk of Type 2 Diabetes in the Prospective NutriNet-Santé Cohort. I am joined by the senior author, Dr. Mathilde Touvier, who is a research director at the National Institute of Health and Medical Research and director of the Nutritional Epidemiology Research Team at the Center of Research in Epidemiology and Statistics at the Université Sorbonne Paris-Nord in France. Welcome, and thank you for being part of this podcast.
My pleasure. Thank you for the invitation.
So congratulations to you and your colleagues for this very important feature article. In this project, you and your team tackled a question of what is the relationship between artificial sweeteners from all sources and the risk of developing type 2 diabetes. So tell us, why was this an important question to answer?
Well, this question was important because artificial sweeteners are present in thousands of products and consumed by millions of citizens. But recently, experimental and epidemiological research suggests that they might not be as harmless as expected, and notably, their impact on insulin resistance and on the risk of type 2 diabetes is questioned.
So this is very relevant to everybody listening, and I gotta say, I'm a little bit scared of what you're about to tell us. But so to answer the question, you use data from the Nutrinet Santé study in France. So please tell us a little bit about the Nutrinet Santé and how this study was conducted.
So NutriNet-Santé is what we call a web cohort. So we launched this study in France in 2009 with the aim to investigate nutrition and health relationships. And it includes today more than 100,000 participants aged 15 and older. And the recruitment is still ongoing. And so its originality and its strength are its highly detailed assessments of dietary exposure. With repeated 24-hour dietary records that include the commercial names and brands of industrial products. And this is very important for the specific study of food additives because the huge variation in composition between two different sodas, yogurts, or other foods and drinks, depending on the brand. And so for the first time, this study quantified the exposure to artificial sweeteners from all dietary sources, so drinks, but also tabletop sweeteners and dairy products and others. And then participants were followed over time, including a link with medical administrative databases, and each newly diagnosed type 2 diabetes case was recorded.
So I like what you said about including the brand names and such, because often we don't even know if there's an artificial sweetener in certain foods that we eat. So it's a very inclusive, I guess might be the right word, within the Nutrinet Santé. So what did your team find?
So what we observed that compared to non-consumers, higher consumers of artificial sweeteners had a higher risk of developing type 2 diabetes during follow-up. And more specifically, we observed associations for aspartame, for acesulfame potassium, and from sucralose, which were the three most frequently consumed artificial sweeteners in this population.
Now, those who were high consumers of artificial sweeteners, though, compared to non-consumers, in your paper, you mentioned that they were more likely to be women, younger, current or former smokers, had higher BMIs and lower physical activity, and they also consumed more sugary drinks, red or processed meats, and ultra processed foods, among other things. Now, to me, that list, a lot of those things on that list are in fact associated with increased risk of type 2 diabetes. So, could it be then that the association you demonstrated just reflects these known risk factors for type 2 diabetes?
Yes, as it is usually observed in a real life setting, the exposure of interest, here, the consumption of artificial sweeteners, is associated with other behaviors and characteristics. Some of them that you cited are rather risk factors for diabetes, while some others, also associated with artificial sweeteners exposure here, rather tend to be protective factors, such as a younger age, lower intakes of alcohol, and saturated fats. And in epidemiology, we are familiar with this challenge to remove as much as possible the effect of potential confounders. So in this type of observational study, we cannot never be sure to eliminate 100% of them, but we applied several statistical methods, several techniques, such as adjustment, for instance, to drastically limit these potential biases. So we are confident that these other characteristics do not entirely explain the observed associations.
So, what is the biological plausibility then? So, I mean, you've explained that you and your team did a number of statistical analyses, and in the paper, you outlined them in detail. But there has to be a biological plausibility for this to make sense. So, what is the biological plausibility to explain this association between artificial sweeteners and type 2 diabetes?
Everything is not fully elucidated yet, but in vitro and animal experimental studies, as well as epidemiological studies, suggested that these artificial sweeteners might induce disturbances in glucose metabolism with a high fasting blood glucose, decreased sensitivity to insulin, increased adipogenesis and reduced lipolysis, and also promotion of a pro-oxidant environment and alteration in the gut microbiota, both in mice and also in healthy human subjects.
Okay. So there is a potential biologic plausibility here. Now, one of the interesting points that was raised in this article was that the population in NutriNet-Santé was actually more health conscious than the general population. I mean, by virtue of them signing up to be part of this, and consumed less artificial sweeteners than the general public. So, can you please put the quantities into context for the listeners? For example, if you were to use a typical can of artificially sweetened beverage, like how much are we talking about? And then also, what does it mean that this cohort may have actually been healthier than the general population?
Yes, this type of profile is indeed current in population-based studies. So participants who voluntarily enrolled in this cohort were more health conscious and tend to consume less artificially sweetened food and beverages. In this study, the mean artificial sweetener intake in higher consumers, so above the sex-specific median, in whom increased risks were mainly observed, was 77.2 milligram per day. So to give you an idea, this roughly corresponds to between half a can and a can per day of artificially sweetened beverages. And so this suggests that the detrimental associations observed here could be underestimated compared to what would be observed in the general population due to reduced contrast between compared categories of sweetener intakes. So to summarize, probably it would even be worse in reality.
So, you mentioned the 77.2 milligrams as the mean artificial sweetener consumption for the high consumer group. I guess my question is, are we able to see as consumers how much artificial sweetener is in a particular product? So for me personally, I don't drink a lot of pops, for example, or sodas, but I certainly do eat other products like I don't know, like a 0% yogurt or something. So can I actually see what's going on in terms of how much I'm having?
This is the difficult part, and it was really challenging for our study because on the labels, manufacturers have to name the substances. So we know that we have aspartame, acesulfame, potassium, and so on, but they don't have to put the doses. And so we don't know exactly how much artificial sweeteners we are ingesting every day. For this specific study, we had to perform analysis in drinks and food matrices to quantify these doses, and we also retrieve these type of doses from different sources. But the difficult part is that it is also variable from one brand to another, but also from one country to another. So yes, it would definitely be useful if industrial could communicate about the doses of artificial sweeteners they put in the products we consume.
Wow. So that's information I definitely did not know. And I guess I'll start looking at labels. But as you said, I may not actually see what's the actual amounts. So finally, then, how would you like these data to be used by clinicians and or policymakers?
Well, this work should definitely be confirmed in other populations and settings, but still it adds important evidence in a context where aspartame, one of the most frequently consumed artificial sweetener, has been classified in July this year by the International Agency for Research on Cancer, or the WHO, as a possibly carcinogenic to humans.
Mm.
We also observed associations with cardiovascular health, previously in NutriNet-Santé. And another point, in 6 countries in Europe, we have a 5-color food label called Nutri-Score on the front of pack of food products. And the international committee in charge of its algorithm also decided this year to penalize artificial sweeteners. So definitely, at least for the general population, the take-home message should be to avoid sugary drink and excess sugar, for sure, because their deleterious impact on many health outcomes, including diabetes, has been proven, but also not to consider artificially sweetened food and beverages as perfectly safe alternatives.
Mm.
And so the recommendation is to try to limit the sugary taste in the diet, and this from the younger age. Habits taken in children are important because they tend to tract in adulthood. So,
Mhm.
no, it is not normal to eat with a bottle of soda on the table, whether it is artificially sweetened or not.
Okay. Yeah, those are very practical, very powerful words that will be, I think, potentially difficult to follow for many people, but something that we should be trying to promote, right, in terms of promoting health for the population. So thank you very much, Dr. Touvier, for sharing your expertise with us today and sharing highlights of your study. I think it's a reminder that sometimes things we created with the best of intentions may have unexpected effects, which is why it's so critical that this research be conducted. So thank you for that. I'm kind of thirsty after this conversation, but I guess now I got to reach for our old friend water, which is probably still our best choice when we are, in fact, thirsty. So thank you again. And I encourage the listeners to read the full article in the September issue of Diabetes Care. Let's move on now to our Diabetes Care Rapid Exchange, where Mike and I chat about some of the articles we found particularly interesting this month.
Sounds good, Alice. Why don't you start us off?
Sure. So, the 3 articles that I've chosen for this month all fall under the theme of challenging dogma. And I'd be interested to see if our listeners also agree and if you, Mike, agree with this overall theme that I've thrown in. So, the first one is from Dr. Rafael Simo and colleagues from Vall d'Hebron University Hospital in Barcelona, Spain, who performed a retrospective nested case control study of people with type 2 diabetes and previous mild or moderate non-proliferative diabetic retinopathy. They selected 1,150 individuals with early worsening of diabetic retinopathy and 1,150 matched controls who had diabetic retinopathy but no early worsening. Then they looked at the magnitude of reduction in A1C in the prior 12 months, categorizing them as rapid, defined as greater than 1.5% drop in less than a year, or very rapid, greater than 2% drop in less than 6 months. Turns out that there was no significant difference in A1C reduction magnitude between cases and controls. There was no association between A1C reduction and retinopathy worsening in the unadjusted or adjusted analyses, and even those with higher A1Cs were not at higher risk of early worsening of diabetic retinopathy. Now, all of this to me, when I was reading it, was really challenging the association of rapid glucose reduction and diabetic retinopathy worsening that we saw in the DCCT and is reported to explain what was seen in SUSTAIN 6 with semaglutide as well. So, interesting data that perhaps challenges a dogma, at least to me, that the rapid reduction of glucose can impact retinopathy.
Yes, Allison, these are very reassuring data for those included in this study with mild or moderate non-proliferative diabetic retinopathy, where these data seem to show that this mechanism is not at play. However, the study excluded those individuals who already had severe non-proliferative or proliferative diabetic retinopathy. And these are groups that the authors do point out rapid improvement of glycemic control can provoke early worsening of diabetic retinopathy. So I think it still leaves us with the need for evaluation to exclude potentially vision-threatening diabetic retinopathy before major intensification of glucose-lowering therapy. Now, Alice, I will try to follow your thematic approach this month with one on food. The first for me is an article by Dr. Jose Garcia Tirado from the University of Virginia and colleagues that evaluated fully closed loop control of glucose during standardized meal administration using a randomized crossover trial in 35 adults with type 1 diabetes. This study showed that postprandial glucose control was still best with the standard hybrid closed loop approach that requires entry of anticipated carbohydrates prior to ingestion, but the fully closed loop approach, even when adding a small dose of insulin, that didn't really seem to improve performance of the system, and again, not to the degree of control as the standard hybrid closed loop. And so, nevertheless, the fully closed loop system still maintained mean daytime glucose time in range above 70%, which is getting at our current recommended target. And so that would still be great for meals where announcement is not being performed.
And I think that being able to reduce the burden of diabetes is really the ultimate goal, right? I mean, imagining being able to put some devices on and then not have to be thinking about your diabetes 24/7, not having to remember to announce that you're about to eat and having that flexibility to just sort of grab something when you need to grab something. I think those are things that those who do not have diabetes take for granted. I think as this technology continues to advance, the idea of a fully closed loop system is really quite wonderful, I think. And I think these data are sort of moving us along the path. So thank you for sharing that with us, Mike. Now, for my end, so to continue my theme of challenging dogma, Dr. Nina Petrova and colleagues of the King's College Hospital in London, UK, they compared the utility of X-ray and MRI as diagnostic tests of active Charcot neuroosteoarthropathy in diabetes. Turned out that X-ray significantly underperformed in the assessment of the hot swollen foot in diabetes and reported as normal 79% of the bones with bone marrow edema seen on MRI. The utility of the X-ray was higher when grading severity of fracture compared to MRI. So I think it's time to rethink the use of X-ray to either confirm or refute Charcot neuroosteoarthropathy, as when the numbers that I just said, I mean, clearly there's an underperformance and a danger of missing a diagnosis that we really do need to catch as early as we can.
Absolutely. I will not argue against the power of MRI here. Hopefully, earlier use of MRI in place of or when the x ray is negative and clinical suspicion is high could lead to earlier diagnosis and slow progression and resulting deformity with this disabling complication. Next, for my food theme, is an article from Dr. Yaogan Luo from the University of Chinese Academy of Sciences and colleagues, examining diet-related lipidomic signatures in a randomized diet intervention trial involving 231 overweight adults with prediabetes and additional samples drawn from over 1,000 individuals who participated in a community-based cohort study. Plasma lipidomic profiles were assessed using high-throughput targeted liquid chromatography mass spectrometry. And interestingly, lipidomic fractions associated with habitual fish intake conferred less diabetes risk, while those associated with red meat intake more diabetes risk based on effects on body mass index and biomarkers of glucose metabolism. And in this population, red meat consisted largely of pork rather than beef. And so I take these results as challenging another dogma, Alice, that pork may be considered the other white meat.
Interesting indeed. I would not have thought of pork as a red meat because you're right. We tend to think of it as the other white meat, but here this was actually put into the red meat category. Okay, well, another dogma being challenged. Now, my final pick is from Dr. Rodolfo Galindo of the University of Miami and colleagues. And the dogma being challenged here is that basal bolus insulin is best for those with type 2 diabetes with very high A1Cs of 9 to 15%. They conducted a non inferiority randomized trial comparing the efficacy and safety of ideglira, so fixed ratio combination of degludec and liraglutide, and basal bolus insulin among those with A1C 9 to 15%, previously treated with 2 to 3 oral agents, plus or minus basal insulin, in the dual high study. Among 145 participants with mean baseline A1C of 10.8%, there was no statistically significant difference in A1C reduction between ideglira or the basal bolus group. Both groups achieved about 3% A1C reduction during the study. As expected, though, there was a lot less hypoglycemia and weight gain with the ideglira group. So this further adds to the evidence leading to the diminishing role of bolus insulin in type 2 diabetes, in this case, even with those with very high A1Cs to start off with.
Yes, and what I found super interesting in this study is almost as might be expected based on these results, the insulin requirements were about half in the degludec liraglutide combination group than in the basal bolus group. So, as you point out, it does make it appear that the addition of a GLP-1 agonist may be comparable to that addition of bolus insulin to individuals on basal insulin therapy for type 2 diabetes. So, my last one may seem a stretch for the food theme, but bear with me on this. I know the frustration my patients experience when they eat the same exact meal at the same time of day with the same starting glucose and the same bolus of insulin, and their resulting postprandial glucose can be anywhere.
Yeah.
So there are lots more factors to consider, but one seldom acknowledged is the variable absorption of that same bolus of insulin from the site of delivery. In the September issue, we have the Derma study by Dr. Andrea Kalus and colleagues from the University of Washington that evaluated insulin pump infusion sites using both non-invasive optical coherence tomography and angiography, as well as skin biopsies. And they found varying degrees of eosinophilic inflammation, fibrosis, and fat necrosis at current and 3-day-old former infusion sites. While the authors suggest such allergic and foreign body type responses to infusion catheters may contribute to infusion site failures, I suspect they may also contribute to the variable response to the same dose of bolus insulin so often experienced by our patients.
Interesting indeed, because you're right. People are certainly frustrated by the scenario you just described about same everything, but yet different results. So another piece to the puzzle and another variable factor that we need to be thinking about. So thank you, Mike, for that. So this brings us to the end of another episode of Diabetes Care on Air. A reminder to everyone to let the people around you know about the opportunity to submit their original art for consideration to be included as a future cover for Diabetes Care. And of course, a huge thank you to all of you for tuning into this episode. We welcome your comments and feedback, and don't forget to subscribe to this series to get notifications when a new episode comes out. Thank you for listening.